So when is the HDU now scheduled to open, if at all?
No one really knows.
Okay.
Thank you.
Yeah.
There you go. We couldn't see that. Yeah, we can't see the camera. I think there's a couple more coming in.
Yeah.
So will it be high flow there or CPAP there and everything?
Just whatever needs HD, I think, yeah. Very much like you. Looks really HD.
You managed it.
Let's say with the back of the
Oh, really?
Oh,
I didn't yet. Okay.
did you all volunteer or?
Yeah. Sorry?
No, they're not going to be rules. What they're going to do is when they get to the person on TV, they're going to use grade 8 and 9 for high frequency on our ward and had it round there to make it interesting.
That's when outpatients will stop feeling as well. I'll be on the floor as well. Yeah. So we'd have to. I don't know about the specialty consultants, so the thought of how that gets rotated as well. Hopefully it doesn't come to that. We don't know. Yeah.
Can't see any more in there now, can you?
No.
Start.
Shall we start?
Yeah.
So most of you here know us, I think. I'm Abhika. Rachel is our team leader. Stacey is the boss for today. We are part of the diabetes team. And we thought we'll start with diabetic ketoacidosis just because the pathway has become more complicated than ever. And it's one of the commonest pediatric emergencies we have. We get about 30 to 35 children with type 1 diabetes in Cardiff, and that's newly diagnosed, and a quarter of them are in DKA. And as we know, DKA is potentially life-threatening. There's a 1 to 2% mortality, and most of you here will remember we had a mortality last year, that was a transfer from the Gwent, and also 6 years ago. So it is a potentially life-threatening emergency, and we have an increased incidence of DKA in children less than 5 years of age. So today's session, we'll just go through this quickly about DKA, the principles of management, and then we'll take you through, probably not, we're not sim trained people, but we thought we'll take you through a scenario of DKA in a 2-year-old who's newly diagnosed. And so we can go through it and debrief at the end of it. Yeah, please. So a quick science refresh on DKA. What happens in type 1 diabetes? Absolute insulin deficiency. There's hyperglycemia. Having said that, the glucose is not available in the intracellular space. So the energy requirements are increased and the body needs energy. So there's muscle breakdown, the liver produces more glucose, there's increased glycosuria, there's dehydration as a result of glucose and water being lost in the urine, fat breakdown resulting in ketones, and metabolic acidosis. And hence, the child has metabolic acidosis, ketonemia, and looks very unwell, more unwell than any other dehydrated child. So DKA, the BSPD and the International Society definition is bicarb of less than 15, pH of less than 7.3, and your blood ketones of more than 3. Urine ketones are not very sensitive, hence we would do blood ketones each time. So in children who have established diabetes, they can have a normal glucose with high ketones. So just remember that they can also come in DKA, but they may have a normal glucose. But with the newly diagnosed, you always get a blood glucose of more than 11 most of the time. Now, what are the principles of management? We all know ABC, resuscitation. The mainstay of management is your ABC, your fluids, managing electrolytes, especially your sodium, potassium, managing the glucose. Midway through the treatment, all of you have noticed how our children go into hypoglycemia. So managing that glucose and preventing complications like cerebral edema. We have guidelines, and the guidelines came out of the British Society of Pediatric Endocrinology guidelines, and also in Wales, we've had the integrated care pathway for the last 12 to 15 years. The pathway was updated last year based on the fluid guidance. We used to restrict tremendously, causing significant other damage. Hence, we have reintroduced fluids as per correcting dehydration in any other child with dehydration. This is the same principles work. Now, where can you find them? On our intranet. It is under the pediatric diabetes guidelines rather than the general pediatric guidelines. So you have the DKA pathway. There are booklets there. The new pathways will come out quite soon, but we're looking for the more recent advances and the nice guidance incorporated into it. This is the DKA integrated care pathway. For children who are not in DKA, remember there's another pathway as well. Say you're taking the child off the DKA pathway, do look into this because it clearly tells you how much insulin to give. The other resources are that. So next slide. Now, the DKA pathway itself, remember to document everything, harass the medics to do their signatures and to document everything they see, because this pathway takes you through all the changes and early recognition of warning signs of cerebral edema, sepsis, and if they document it clearly, it's great. The other aspect of it I would suggest is documenting your variance and comment sheet. When we audit this pathway, it's very important that those documents are made. Remember, guidelines are just a guideline to treat an unwell child, but each child is different, so there may be variation in what you do. But do document that, so it will help us to update the pathway. So the pathway is clearly laid out by traffic lights, red, amber, green, alerting, escalating care, and information is in blue. And also the comments section, not the comments, it's the appendix, is the main protocol, complication section, and your explanatory notes, etc. So it's clearly laid out that way. Now, coming to where we start with obviously the history. The child comes, history of 40s, which is toilet thirsty, tired, and thinner. And the symptoms of DKA, which would be vomiting, confusion, abdominal pain. Signs would include Kussmaul's breathing, which is a deep sighing respiration, and many a time it's mistaken for a chest infection. So do glucose. Any doubts, finger prick blood glucose, and you have an answer. Biochemistry, you have obviously hyperglycemia, acidemia, and high ketones. And then suspect DKA, ask for senior help, and then you record accordingly. ABC of resuscitation, I don't need to go through this in detail, but airway. If a child has a low GCS, yes, you have to protect that airway. In children with DKA, intubation is the last resort, simply because the hypocardia as well as the sedation you give will exacerbate a cerebral herniation. So you have to remember that it's the last resort. So maintain the airway, see what else we can do. Is there cerebral edema? Where can we manage that and go on from there? Breathing, give 100% oxygen if required. Now the crux of the treatment is circulation. So the weight, it's useful to have an actual weight, but estimated weight will be fine if the child is very unwell. And shock. Assessment of shock is as per your APLS guidelines. So we've taken it all back and said, if there is shock in a child, your fluid bolus as per APLS guidelines. And the same parameters remain, that's tachycardia, prolonged capillary refill, poor peripheral pulses, hypotension, although you know that's a late sign, and not just poor peripheral perfusion. Like I said before, children in DKA do have poor peripheral perfusion because of the metabolic acidosis and the ketonemia. And the aim is to restore adequate circulation. These children are thirsty, they wee a lot, they are dehydrated. So it's important to assess dehydration and treat accordingly. Now, with the poor peripheral perfusion and how unwell they look, it's difficult to assess the degree of dehydration. And evidence has shown us that it's all user biased. So what we've done is we have grouped it in based on the pH. So mild DKA with 5% dehydration is 7.2 to 7.29. Moderate DKA is 7.1 to 7.19. And severe DKA is 7.1 and below. Now, we have made changes to the mild and moderate. It's not 7.7% dehydration. Mild and moderate treat as 5% dehydration. Severe dehydration treat as 10% dehydration. So those changes will come in the new pathway. Now, bolus fluids. For all children in DKA, whether they are in mild, moderate, or severe dehydration, we have recommended a bolus of 10 mL per kg. But the rehydration bolus, what we've termed it as, is given over 1 hour. The advantage of that is these children are dehydrated anyway, so we rehydrate them quickly. It gives us time to do the complex calculations with a clear mind, 2 people checking, and the insulin, everything is calculated, and it buys time, and plus keeps the child safe. Resuscitation bolus is given as per your APLS, the 10 mL per kg bolus, quick bolus, reassess, and that it goes through that pathway. The rehydration bolus should be subtracted from your fluid calculation later for your maintenance. Whereas the resuscitation bolus should not be subtracted as per APLS. Now, fluid deficit calculations. It's the same as any other child. it's 5 times, 10 times the body weight, or 10% dehydration, 10 times, 10 times the body weight. But the fluid deficit is corrected over 48 hours, is replaced, sorry, over 48 hours rather than 24 hours. And that is because rapid fluid resuscitation or deficit correction has increased incidence of cerebral edema, or thought to have increased incidence. Hence, that fluid deficit is corrected over 48 hours. Maintenance. Now we've gone back to maintenance fluid as per the Holiday Sega formula, which we use for any child in pediatrics. So that's your, weight, the first 10 kgs, the second 10 kgs, and the third 10 kgs, onwards. So that's the same thing. So maintenance fluids plus deficit, you get the calculation. The calculation can be done very clearly on this pathway. If you're not finding the pathway for some reason, there is an online pathway or a BSPD calculator, where there's a link through the DKA, the diabetes webpage, and you can go through that quite easily and check if the fluids are right. But I'd rather we use this so that there's clear documentation and we could audit it later. So what fluids would we use?
But now,
Yeah, maintenance fluids.
I think it's a trick question.
So the fluids we use are 0.9% with 20 millimoles and 500 mils. And those bags are there both in CAU, in the wards, as well as the emergency department. And the reason, and the next slide. And the reason we use that is there's hypokalemia because of the insulin infusion. Now, starting insulin, the rehydration bolus does buy us time to start insulin later. There is some anecdotal and retrospective case note analysis evidence to show that insulin started earlier has a risk of cerebral edema. Hence, it should be started 1 to 2 hours later. We used to start in all children about 5.1 units per kg per hour. We have noted an increased incidence of hypoglycemia with that. So all children, 0.25 units per kg per hour. Severe DKA or adolescents with existing type 1 diabetes, it's useful to start 0.1 unit per kg per hour. Children under 5 years, blanket, start 0.05 units per hour. If they're on the pump, stop the pump, stop all short-acting insulin. Now, the important thing we have to remember is in existing patients, start their long-acting insulin, give them the long-acting insulin. In newly diagnosed, it's useful to give the long-acting insulin because the following morning, when we're taking them off the pathway, then we have to play catch-up. And there is some evidence to say it shortens the duration of the DKA episode. So start the long-acting. Children less than 5 years, it would be Levemid. Children above 5 years, it would be Lantus. There's a new long-acting insulin which you might have come across called Receiver. It's not in our protocol as yet, but that's another consideration the diabetes team might have. Now, where does the child head from EV? It's always a contentious issue. So all children with DKA should be admitted to the ward or HDU setting with a 2:1 nursing care, and that's as per national guidelines. Those are high risk, which would mean pH of less than 7.1, that's severe DKA, less than 2 years of age, who are in shock, who have a sodium of less than 130 or more than 150, who have significant potassium abnormalities, altered conscious state, or significant hyperglycemia of more than 50 should have 1:1 nursing care. The nursing care would include strict fluid balance, capillary blood glucose 1 to 2 hourly, capillary ketones 1 to 2 hourly, hourly observations of BP and modified GCS, cardiac monitoring, which happens. But the twice daily weights don't happen. The twice daily weights are extremely useful once the child is able to stand to assess the degree of dehydration, how we are recovering, and it's useful to have that, and especially a discharge weight as well.
as in coming off the pathway rate as well. And any changes in ECG trace report immediately, and any signs of cerebral edema report immediately. So this is the whole chart, which most people hate. We try to make changes, but the fluid changes happen so frequently, it was impossible to make changes. But it's self-explanatory, and most of it is filled excellently on the ward. Medical reviews be after the medics to review at diagnosis, 2 hours after, and every 4 hours, and that should be face-to-face review with updates of the parents. Now, complications, we're looking at cerebral edema, hypokalemia, hypoglycemia, and persisting acidosis. So these are the 4 main complications we have to watch out for. Next slide. Cerebral edema, the early signs are headache, drop in heart rate, increased blood pressure, and agitation or irritability. The late signs are obviously, you have the GCS falling as well as posturing, and we should catch them on the earlier signs. I've seen 2 children presenting with, 3 actually presenting with cerebral edema. 2 of them had presented at diagnosis. So again, we don't know why cerebral edema happens, but it's mostly at diagnosis. But if there's cerebral edema, make sure it's escalated to the consultant on call for the day, and a hypotonic saline is available, given mannitol, reduced fluids, think of imaging. And like I said, for these children, intubation is the last resort. And it has a very poor prognosis, with 3/4 of them having significant ongoing problems of neurodisability. Hypokalemia we see all the time. We play with the potassium, don't we, Chris? So what do we do about it? The new guidance, which will come out in maybe a month or 2, will say if the potassium falls below 3.5, you have to escalate to HTU and say, are we thinking of a central line? Because the potassium has to go through that. Older children, you can give oral potassium, so make sure we have oral potassium ready. When the potassium starts falling below 4, think of oral potassium. Also think of reducing the insulin, stopping the insulin for about half an hour. We can't stop insulin for longer simply because the ketones will start climbing again. But these are the things you have to think of with the potassium. Hypoglycemia, when I did an audit of the pathway, 50% of the children had hypoglycemia. So when the blood glucose starts falling, add dextrose. How much does 5% dextrose contain? Just 5 grams in 100 ml. So in the whole day, the child will get about 50 grams. We require about 200 grams of dextrose or carbohydrate. So it's just minuscule. Don't hesitate to add 5% dextrose, increase to 10% dextrose if required, reduce the insulin if required. Persistent acidosis, this happens, and this is not a good sign, in which case calculate the anion gap, go back to the beginning. Is the insulin going through properly? Are the fluids going through properly? Has this young person taken anything else like salicylates? Is there sepsis? So the management changes. These 4 things, if you're suspecting that the things are not going right, but go back to the beginning each time. Many times the children are fine from 10 o'clock at night. The SHO at night doesn't want to take them off the pathway. The registrar at night doesn't want to take them off the pathway, and the nurse is quite frustrated. So because nobody wants to take that decision, push them to take that decision. If the child is eating and drinking, convert to subcutaneous insulin. If the child is on the pump in an established child with type 1 diabetes, put the pump on with the basal insulin and run the IV insulin for 1 hour and then stop it. And then you can give a bolus 1 hour later, just before, if they're eating. Am I right, Rich? Yeah. And if If it's a newly diagnosed, you have to give Novorapid. So give the Novorapid. The child can eat and drink whatever they have to, and then half an hour later stop the IV penicillin. So it's as simple as that, and we come and pick them up the next day. Over to you, Steph. Any questions on this?
Yeah, I think when you look at it, you guys are probably quite familiar with it anyway, I think, but maybe not on our so much. I think when you've got it in front of you and you work through it, it's logical how it follows, when you're working out the figures and going through it, and then it does, like Dr. said, it gives you time, once you've set up your fluids, not to be panicking too much, but getting that instant or everything ready all at the same time, you've got 1 to 2 hours before you need to set that up. So it does, and you're not on your own, you're a team effort. This isn't easy to lead, this is you working alongside your colleagues as well.
Where we will probably work in, it's a lot of the early stuff, like the fluids and stuff is done now on TV. It's actually all, obviously we have to double check it once they get there, but actually a lot, normally the fluid resource has been done.
Absolutely.
They're already on the insulin. Just after the pump fluids, and then we're going to start the insulin and half an hour after they get to work. So a lot of the initial paperwork is done. Sometimes it takes.
Please, how do I make that screen bigger?
Make it bigger.
It's very weird.
Us, can't you?
Yeah, that's true.
Like presenting
Then
view,
things
is
start
it?
creeping up,
Sorry, I'm
hypoglycemia,
glaring into the camera
now.
I've got my glasses. Look, so just want
Actually,
to-
they've worked a lot with the GPs. So this year we haven't had many.
I don't want to stop
DKAs
it
come in,
recording now.
Because
Oh,
diabetes
is
does
it because
get
we're-
recognized first in primary care, and delay in diagnosis is responsible for DKA. So the few
Don't know
we've
why
had,
it's not doing it.
we've had a deluge of type 1 diabetes. We have had 30 cases already. So, but we haven't had much DKA from.
I don't know. How can we do it so that we're the main? I don't think it matters to, I don't know whether it matters to people at home. Can everyone see us at home? Can you give a thumbs up or something? Yeah. Is
Yeah,
it
I can
is
see
it
you.
okay? Yeah, okay.
Yeah.
Sorry.
So yeah, we just thought we'd try and do it. It's just great having all this theory and stuff, just putting it into practice and a few practical things. But you guys constantly very kind of chat and do all this more than we do, even because we tend to come along. Well, we obviously come and meet the family and are involved, but we start all our education then when the child is usually down on island or sometimes we do start it beforehand, but usually the families are so upset and distraught and their child is unwell, so they want to just be focusing on them. So the education usually kicks in after, but it's good to have. We just thought we'd try a bit of a simulation session. So bear with us. Sorry, I got my back to you guys there then. I'll try and do it from that side in a second. So is everybody, I don't want to put anyone in an awkward position, but is everyone happy to participate and we'll kind of all have a little bit of a role, if that's okay? Or if people are really against it, don't worry, but you can observe and just contribute bits and pieces. So we have got a scenario that we're going to share with you, and we just need to have is Gabby going to be on?
Yeah,
SHO.
given her that.
Marvelous. So we've got Gabby for our SHO. We've got Mum, right?
Yeah, more like a G mark.
A glance. And then we need two nurses if possible. So a nurse from our emergency department and then our ward nurse. So who would like to participate? Go on. But everybody is going to contribute because we're all kind of, we're just going to sort of throw some things out there and do you do feedback now? Or do you do that?
That we can leave it there.
Okay.
I think what we want to
This is our complete.
Okay. Do you think this is the right one?
No, give me the wrong one.
These are the ones who want it. So we have a 2-year-old girl.
Yeah.
You need another one.
We need another one.
Sorry, guys, that's how it is.
One more aliens. Yeah. Amy.
Okay, so we were going to do 2, but we decided to stick to 1. Might make it a little bit confusing for us if we did the 2 different ones, but we thought. So we have a 2-year-old girl that is referred to the paediatric assessment unit by her GP. She's got a 3-week history of weight loss and polyuria, and has now started vomiting, and is noted to be pale and lethargic, pale and irritable, sorry. There's no fever, but the GP wants to rule out concurrent infection, so has sent the child in. So,
Chris. That's one.
what are you, Chris, the ED nurse?
Yes.
Okay. And what are we gonna do first of all? We've got a really upset mother here.
Take a moment to super away, obviously, and just try and reassure you. Hi, I'm Chris. I'm just here to help the session baby. What's your name?
Jane.
Jane, hi Jane. Hello, look. And Chelsea doesn't fantastic, so I'm going to swatch down. So I'm just swatching down. She's not very great colour.
Okay.
And I'm going to call one of the doctors and see her. So I'm going to get one of the doctors to come over. Either take you or whether you're in the department already. And just say Jane has come in with mum. And she's been on for about 3 weeks. And that's just doesn't get the top swatching on. Just popping some monitoring there as well.
Sure. Hi, Jane. Hi, I'm Gabriel, I'm the pediatric doctors in the team. So because what's your little child's name?
Her name is Jane.
Her name is Jane, sorry,
Yes.
your name is
Samantha.
Samantha, right? So because Jane doesn't look well, I just started with an initial ABCD look. So looking at her airway, is she maintaining her airway? Is she crying? Is she breathing? Okay, so the airway is patent, she's breathing spontaneously, and we're going to assess her perfusion. So she looks pale. I'm going to check her capillary refill by pressing on the sternum for 5 seconds.
Heart rate 168, respiratory rate 45, cap refill 4 seconds. Go-to sats are 99%, but we have got oxygen on as well.
Okay, sure. So she's got a poor perfusion. And can I feel bilateral femoral pulse as well?
Yeah, not strong.
Sure. And I have a quick listen to the heart, make sure the heart sounds like do I listen to both bases of the chest, and is that all right?
Sorry, what's that?
I was going to listen to the heart.
Okay,
quick
yeah.
Find anything wrong with the heart.
No, nothing else wrong with the heart.
And a quick feel of the abdomen. Is it soft?
She's a little tender.
Okay, sure, all right. So I think the main concerns is that she's got poor perfusion. She's likely to be hypovolemic. I'll just do a quick history. So I understand that Jane's been vomiting for the last 3 weeks. Is that right?
Yes, yeah.
Yeah, sure. And is she otherwise usually fit and well? Any medical problems?
No, nothing before. Really, normally really healthy.
Is she allergic to anything?
Not that I know.
On any regular medications? Okay, sure. And besides the vomiting for the last 3 weeks, so passing the arrival with us?
Yeah, she's been reading quite a lot actually.
Okay, sure. And has there been any weight loss?
Not that I've noticed, but I don't know if I see her every day. I'm not quite sure.
Anything else? Any fevers at home?
No,
Coughs or colds?
No.
Diarrhea?
no.
And Samantha, I think Jane looks very alert and well at the moment. I think we just need to do a few initial investigations. So if it's all right with you, what I'm going to do, I'm going to pop a drip in her arm. And I think we're just going to give her some fluids. She's quite dehydrated at the moment. And while we do that, as well. We're going to take some blood samples off it, and then what Chris, if I can get you to do, is do you mind checking my blood sugar and my blood ketone as well? Okay, then you can take it from there, and I'll have a good chat to you as you kind of look through all of this, all right? But don't worry, she's in good health. We'll just take it step by step.
Okay.
Something with blood glucose.
They have blood glucose is 32 millimoles.
Yeah, I'm just thinking that one.
Five.
5, thank you.
True. So I think with all of those numbers, it's pointing towards the direction of DKA or diabetic ketoacidosis. So it seems like Jane might have diabetes, and one of the complications is sugars can get quite high, and some of the ketones can get quite high as well. So what that means is that she's not able to produce as much insulin as what her body requires, and that's why her sugars are very high. So what we need to do, like I mentioned, we've already popped a drip in her, but the first thing we need to do is to rehydrate her before we give her that insulin. So I think because right now there's only 2 of us, we might think about gathering a bit of a team to get some extra hands on board. And I know we've got a DKA, a very nice DKA pathway, which we can work through. So we'll give a fluid bolus of 10 mils per kilogram. I think we can do that within an hour. We work that through the booklet, and then we get our team.
Do we want to
the kids
do
will
fluid
be-
calculation on the board? Sir, here. And if anybody wants to subscribe or do you want to shout out their mind, whatever you want to do.
Sorry, I don't know what you said.
Say that again. Sorry, does somebody want to describe the fluid calculations up on the board? Yeah. Or you want me to? So I'm just going to say we've also done some bloods at this point now. We've got a gas back. So our first gas shows that she has a pH of 7.01. So yeah.
So we looked through the protocol. So she's got a pH of 7.1, and then did you have bicarb?
7.01.
7.01. Yeah, 5.3.
Bicarb of 5.3, and she had blood ketones of 5, and so she's definitely in DKA. She meets the criteria. So we go down. We've already done the initial assessment, all of that. And then go to the resuscitation bit. So we've already got our blood and our blood gas, and we know her weight 15 kgs.
Shall we go back a bit, Gabby? Shall we go back a bit and think of the airway bleeding circulation again, because she's in shock with the criteria?
So we're treating this little one. Do we think that we need to treat her as if she's in shock with a catheter level 4, tachycardic? Is that right?
And the blood pressure and
Blood pressure.
Yes, we do. So we do need to give a 10 ml. So as per APOS, we should give a 10 ml per kilogram bolus, so 0.9% saline, and we do that every 15 minutes. And then we reassess the bolus. Yeah, I just don't say that.
Maybe I'll show you that. You can check out the temperature.
Okay.
Which is
Yeah.
150.
We've got some fluids here. If anybody wants to run any fluids through.
Exactly one of them.
Well, up to you. You can if you want to, or we can go for the 10.
Yeah.
If you want to wait for the slide.
Yeah.
Well, 150 minutes.
And also because this child is in shock, sorry, I kind of slipped my mind initially, because she's in shock and she's not well and she's reading a fluid bolus for 15 minutes. We should call the registrar as well.
Yeah.
And I think the consultant should be aware that we'll have the registrar make the decision and bring the consultant.
Okay. So the first fluid.
the registrar has just got back. They are busy with acute salicylate poisoning. They'll come back as soon as a consultant has been called.
Okay. What we should do, or we have that
So you've given the first fluid bolus, and then what we're going to do once that's gone through, thinking back to our ABC.
We're going to reassess.
Reassess, yeah. So the new odds are that the stats are 99, respiratory rate is 42, blood pressure 82 over 45, heart rate 170, it was 168 previously, and after we refill is 3 to 4 seconds. We need to do now.
So this child is still in shock again, and so she clearly needs a second fluid bolus. But this is obviously she's unwell, and I don't think PICU are aware of her yet. So we should ring the PICU team, speak to the PICU consultant, and the PICU registrars are on call because we've got a very unwell child with PICU. I think because this child is still very unwell, needing a second fluid bolus, and obviously because I'm the only SHO on the floor, I think we should ring up PICU and see if they can come and give some extra hands as well. So the PICU team are on there.
Brilliant.
So what are we going to do about fluids? Go ahead.
Hi, my name is Gabrielle. I'm the pediatric SHOs down in the children's assessment unit at the moment. I was hoping to speak to the pediatric registrar who's on call because I've got a very unwell child that I'm seeing I'm very concerned about. So I've got a 2-year-old child who's normally fit and well. She's came in with DKA in shock. So she's got a pH of 7.01, a bicarb of 5 point something, and she's got ketones of 5. She's in hypovolemic shock with a capillary refill time of less than 3 to 4 seconds. She's tachycardic and she's hypertensive. I've already given her 1 fluid bolus of 10 ml per kilogram over 15 minutes. I reassessed her. She's still in shock again because she's still tachycardic with low blood pressure and a poor refill time. So we're currently running the second fluid bolus. So I'm the only doctor currently seeing that my registrar is tied up. I'm hoping to have extra hands in the mind to come down and help me with this child because I think she's got hypertension.
Well, thanks, Gabby. We'll be there in a couple of minutes.
So the second fluid bolus has been given, and what are we going back to now? We need to reassess again here. So our new odds now are that's 98, respiratory rate is 36, heart rate is 152, and cap refill is 2 to 3 seconds.
So that's improving. She's a 2-year-old child, but she's still on the more tachycardic side as well. The refill time is 2 to 3 seconds, so that's normalizing. I'm a bit cautious about giving the third fluid bolus because it's normalizing. I think at this stage, because she's kind of in a grey area, I would have ideally like to discuss either the PICU range or how is it available for the third fluid bolus, because I feel like we might be going over what we give the third fluid bolus. I'm more inclined to start the maintenance fluid and then reassess her. And then if she deteriorates, then I'll then think about the third fluid bolus. If the rest of the team are on board with that, what do you think? Yeah. Yeah.
So we're going to discuss with your
Finish.
that's discuss. Okay. So yeah, they've agreed that we now need to move on to the next stage of the DKA pathway and think about the fluids that the calculating the fluid deficit. We've given the reset the fluid boluses for the shock, and now we're going to move on to the fluid deficit. So what from the DAS, do we think the child is in severe, moderate, or mild DKA? She's a pH of 7.01. Sorry, so severe. So we're going to assume a deficit of 10%. Yeah. Okay. So the calculation for that, I don't know whether you got it. So it's the weight 15. Weight times 10 times 10.
Good.
And that is calculated to number of replace it over 48 hours. Yes, so divide 1500 mils by 48 hours. 31.2. I'll be kind and give you that. Come on, it's like what's the maths program that you do countdown? When you do the math? No,
So we got a calculator.
you've done it.
So 1.5, yeah. And then so we put the 1,500 in. And then so we don't subtract any bonus because we've given the resuscitation bonus. I'm just trying to get on to the junior so that's still They now have to take.
Oh, let me.
Invalid code.
Yeah.
Still not.
That's all right, I'll probably do it.
So 1,500 divided by 48. So 1,500 divided by 58 is 31.2.
No calculator needed.
No calculator.
No, just came right off.
Yeah, impressed.
Okay.
So that's 31.2 mils per hour.
And just remember with these fluids, this fluid isn't subtracted then later on. It's only the arm if they aren't shocked and you're giving that fluid bolus there. Okay, so maintenance fluid we work out in the normal way that we do with all children. So 100 ml per kilo for the first 10, 50 for the next 10 and 20 thereafter. So she's a 15 kilo child. So how much are we going to be giving her the maintenance fluid?
How do
So
you
you
make
need
it?
to just, yeah, because you've got to add this. This is the fluid deficit. Got to add it to maintenance fluid there as well. So it's 10 times 10 is 100 times 10 is 50,000, and then you've got your 50 times 5. Yeah, you're not going to add this, but remember this is on 48 hours.
This plus this,
and the maintenance is help this with 24 hours.
Oh,
So you
Thirty-one.
will add the 31
31
goes in
goes in
that
that
box. Oh, right. I'm just going to work them out separately. So if you just do this two separate, think of them as two separate cells. So you want to do your fluid deficit, right?
83 mils an hour.
But work out what maintenance fluid will be for 24 hours.
Push it work out.
Divided by 24. Yeah. And then you're going to add those two together to make that bracket.
And then we have to sign all these things.
Yeah, brilliant. Okay, you got your maintenance fluid.
Maintenance fluid running up.
We all agree. Good. Okay, so maintenance of fluid is set up. So what do we need to think about doing now?
Isn't it reassessed every 2 hours, every couple of hours and then take notes, isn't it?
Yeah.
Right?
So I think now we've bought time because we've got a maintenance fluid running up for sort of about 1 hour to 2 hours before we think about starting insulin. But I think we need to tidy up a few things. So we sent off some bloods when we put the cannula in, and hopefully that should include, hopefully I would have taken the initial type 1 diabetes bloods. I should have sent that over, I hope so. But do I have any results from like the urea electrolytes I sent off through that cannula?
Sorry, have you got to put the piece of paper now? So these are the initial blood results. Would you like to see? And we've got some on the back as well. That's your first sample that would have gone off, and then you've got some on the back as well.
We've got a normal full blood count. White cells are all normal. Calcium's normal. CRP is 4, so that doesn't suggest there's an infection. But because I only took a very brief history, I think once everything is set, I would go back and recap and take a full history. So we got a glucose of 32, which we already know about that. Glucose is okay. Coagulation is okay. So our sodium is low, it's 125. But I know when you have diabetes, you can get a falsely low sodium, you can also get sodium loss. But I think once I'll have to have a look in the protocol because I'm not quite familiar with it. Because I know there's a correction that you can do, a sodium correction, but I don't know when do you do that and whether you should recheck another blood gas and lab electrolytes sort of after you've done all your fluid resuscitation. I think I probably would recheck sort of once the IV fluids have gone through over an hour. But I think at a sodium 125, that's quite very concerning. I would stick
Anything
to
you
the
want to
normal
help Chris on
cells.
this,
Sorry.
on the sodium? Because the sodium we see, shall we debrief here for
Yeah,
about the
okay.
sodium because it becomes more appropriate.
like you said, they'll have a false sodium, low sodium simply because of the hyperlipidemia which occurs and hyperglycemia as well. So there is a formula at the back of the pathway for corrected sodium. It's important you put the true sodium plus the right to corrected sodium. So if the corrected sodium is between 135 to 145, I wouldn't buy. We wouldn't give sodium corrections to children with NDK because you need to look at what the sodium is doing. The sodium should increase appropriately as you treat the DKA. And if you see that the sodium is falling, you think of things like cerebellar. It's one of the markers. That's why we say just put this, write the lab sodiums on that sheet and write the corrected sodium as well. In the back of the pathway, the corrected sodium calculation is there.
Okay, so that's good. That's answered. We can keep an eye on that. That's great. And the potassium is 4.7.
The child has passed urine
Okay.
and the
child's
ECG looks normal.
Okay, so that's fine. So if the child's passing and the ECG is normal, they can carry on having the fluids we're giving at the moment with potassium, so that's fine. Okay, so the bloods are all okay for now. And we've got maintenance for the going.
It's been about an hour now since the fluids have been set up. So what do we need to think about establishing?
So once the glucose, especially the child into 5, should be 0.05.
Is the insulin? Yeah. So we're going to think about setting up. We want to get the insulin set up now. We've got a 1 to 2 hour window there.
Yeah.
So there's no panic, no rush, and it's something that you need to take your time in doing and setting up correctly. But yes, so this baby, Jane, sorry, is only 2 years old, so she will be on that dose. But if you're not sure, it's worth contacting one of the team if they are really critical as well. It's worth contacting one of the consultants on board. Yeah.
And just remember, you call the registrar or the SHO registrar, you can call the pediatric consultant directly as a legitimate, simply because we are happy to be called. I think all of us are happy to be called. And also, if there is any doubt, they will liaise with the endocrine consultant on call.
So one's about more than an hour, so we can start the insulin.
So how do we work out our calculation then of our insulin and what we need in our syringe? So yeah, that's the amount. So it's 0.05 units per kilogram. She's 15 kg. There's another calculator job, definitely.
So I presume we would have
Oh
checked.
gosh, anytime can do that.
Because, yeah, I presume we would have checked the glucose because it's been an hour as well.
Yeah, so the glucose is still high. 27, yeah.
So that gives us 0.75 units per hour.
Okay.
So say start the rate, and we just take the time.
No, yeah, we
Yeah.
can.
Do you know what insulin that you're using? So attractive, and make sure that you are making it up, obviously double checking as it's special, but and it's so you've got 49.5 mils of moving saline and 50 units goes into a 50 mils syringe. Okay. That makes sense.
Yeah, because it's
It makes sense for us to do it.
It's
though.
it's
Yes,
100
no,
units in a mil in the act rapid.
Yeah.
So you take half a mil, so you 49.5 and say like plus 5.5
Yeah, yeah.
mils. So
So you
you
need
get
to-
50 and 50, so
Yeah.
calculation that's right.
Yeah.
And you can start that going then. And what are we going to be doing from a nursing point of view for our observations and things now?
Constant monitoring.
Yeah.
Just, yeah.
So fluid balance is really, really important as well. It's really going to guide us. And if we do need to, it doesn't happen very often, but if they are particularly young or quite sick, then consider catheterization if we need to. Is that fair? What would you say? Or?
For catheterization and NG tube, unless it's absolutely necessary, we wouldn't do it. I know in PICU, HDU, they do a lot of characterization.
Yeah.
But we wouldn't, because DKA is a very difficult start for a child with diabetes and the family. When you get an estimated fluid balance with measuring nappies in a little 2-year-old. And same thing with the NG, unless the child has a compromised airway, reduced GCS, I wouldn't put the NG in. Simply because there's no need for tubes which are not needed. If there's any doubt about the GCS and things, NG goes in, and you can put the catheter.
So this is where we're doing our hourly blood glucose checks as well, okay, and ketones as well, 1 to 2 hourly. So as the infusion now has been running for a couple of hours, but our HDU nurse or ward nurse has noticed that the blood ketones aren't improving. So they've gone up slightly. What we're going to do now?
Okay, so I think I'm not showing up to the doctor then. Yeah. And also the tachycardia, mentioning that at the same time.
Lovely.
Yeah. So I think we'll reassess from an ABCD point of view. Is there any change to the airway and the breathing?
No.
Okay. Then we'll reassess from a cardiac point of view. What's a perfusion, central perfusion doing? Are we still well perfused?
Capillary fill 2 to 3 seconds.
Sure. And does the child feel warm, and is the femoral pulses well palpable?
Yeah.
Okay, fine. So the child's not hypothermia, but adequately and rehydrated. And is the child responsive?
Responsive GCS 50 by 15.
So I think we need to think as to why is our ketones not improving. What was the ketones again?
They were 4.5.
4.5. And what's the glucose?
Glucose is now 18.
18. Okay, so the glucose is coming down, but the ketones are not improving. And the child is tachycardic, no temperatures, nothing. Okay. We're already on 0.05 of insulin as a 2-year-old child. And what time of the day is it? Have we thought about a long-acting insulin?
We could think of long-acting insulin. That's a bit harsh, I think, that to say that you go through that. But if the ketones are not improving, it's usually because of your insulin. Insulin is the one which switches off the ketones. The blood glucose will go down with just your fluid boluses. So if the ketones are not improving, is the insulin not going in properly? That's the question you ask yourself. You go check your lines again to say, oh, the ketones are not improving. Do we need to increase the insulin, or is the line blocked? So go back to the beginning to check. Go back to, is this child septic? Those kinds of things. That's all the ketones.
Yeah. So I mean, but we would have checked the line. We're happy that the cannula is going in.
There's a little bit of a block. So
It's a bit of a
reinsert the line.
That's being relieved now. So things are starting to move better. Okay. So you carry, yeah. Okay. So we're keeping monitoring the child, and we've done another blood gas. Just have a look. Things on the back of this one. Sorry. This one, sorry, blood gas pH now is 7.28. Vital is 12.
Glucose is 6. It's fallen though from 32 to 6 in 2 hours.
That's quite
What
good.
would you think? Yeah.
That's dramatic.
We'll have to add some glucose because it's gone less than 14, so we should add some dextrose. So at 5%, we'll have changed it to 0.9%, normal say 5% dex with the 20 millimoles of potassium, and check the blood sugar for half an hour just to make sure that it's coming up.
Incidentally, the potassium is also 3.5.
Seems 3.5. Look, 3.5 is still within the normal range, still acceptable. So I think I'll be happy to hold for now because we know that we got insulin and that pushes potassium to go back in again. It's still normal. And if we're going to recheck the sugar after starting dextrose and sort of half an hour, I think we can always recheck a blood gas just to make sure that the potassium is normalized as well.
What else would you look at? ECG changes. Which has come to you and told you there are some ECG changes.
Okay. And what do I see in the ECG? And I know I see
The broad T waves.
broad T waves. Peak T, as in like low T wave?
Peak T waves and hyperkalemia, isn't it? So sort of that.
Okay. Low T waves. Okay, so the child has okay, fine. So the child's potassium is 3.5 and there's signs of ECG changes suggestive of hypokalemia. So that's concerning. So again, I would bring the registrar or the consultant, and am I in a HDU setting right now?
Yeah.
Okay, I think because so fine, in a HDU setting, I will go notify the PICU registrar as well, because I think we're already on 20 millimoles of potassium. We can't give any more through an IV line, so it's going to have to be given centrally. And I don't think that's something that we can do on the ward, and then central access as well.
Yeah.
So I'll speak to them and discuss about potassium replacement centrally.
If the child is well, you're not seeing any ECG changes, then you can consider oral potassium.
That's a great question. As we put that big jump 56, so we're almost at the point where you'd have 10%.
I would agree.
So would you just jump to 10%?
I would jump
if
to
you're going to
10%.
continue to have that fall.
Because you've had a significant fall in blood glucose. If you wait for another hour with 5% dextrose, you're not going to see it's probably 3.5. So jump to 10% dextrose. The next option would be reducing the insulin.
I'll be guided by the boss.
No, I always say, Lectus pointed that out because he has so much experience. When Lectus call me over the phone, I'm all in my car coming in. So it's just that.
So things have started to improve for Jane. She's much, her blood come back. She's much more settled. Her observations are stable. I think I said, this one. Very happened. But I think we've got another gas, and she's 7.34. And yeah, she's the blood glucose is stable. Things have much improved. What are we going to think about doing now?
You've given the level at the previous night, so you did well there.
Okay. If things are normalized and we check and keep, are they still ketones in the urine?
We're not checking urine ketones, but
Also
her,
not urine,
her blood ketones are now less than they're 0.6.
Sure, so that's less than one. I'll have a chat to the nursing staff on the ward, because they would have been around her and see what she's doing sort of clinically. Is she eating, drinking, playing, active? And I think as per the protocol, we can think about sort of converting over to sort of subcut and stopping IV fluids, depending how she's doing and stuff. But we can do this.
Fantastic.
Brilliant.
Before you guys move to the night, delegation for you in the world.
Yes, do that.
We'd rather that.
Yes, it's really useful to know that there's a patient
There's a
on
patient
board.
at the
So
ward.
as soon as we come in, we can
So,
plan
yeah.
our days.
Even in the middle of the night, if you leave a message in the office phone,
Yeah.
it's fine. We pick it up the following morning, don't get it.
Yeah.
And just as Dr. Shed said earlier, whoever, so if it's a child known type 1 that's come in and is normally on a pump, we want to get that pump, and the parents are very, obviously they're on a pump, as you know, pretty established, so don't be frightened by the pump. The parents will be there to set it up, or the child themselves, if they're old enough, hopefully they might not be great at that point, but they will know what to do, and they'll go back onto their usual settings. You won't need to make any changes or anything to it, but get that pump back on them and get that basal running in, and then an hour after that pump's gone on, the insulin infusion can come down, and then hopefully they're feeling if they want to eat and drink and have a bolus for that. If it's a new child, newly diagnosed type 1, then obviously we'll be starting them on the insulin regime. So there is the newly diagnosed booklet, which we showed you in the beginning, to work out those insulin calculations as well, to prescribe them for you to double check as well. And if they feel like eating and drinking, then we have just to bear in mind that we do want to get them off the pathway, but just make sure that they are, before you give that Nova Rapid, that they are going to try and have something to eat, because there are times where you come a little unstuck. So we think they're going to eat, and then we give it, don't we? And then maybe they don't feel like something, but just offer them whatever, whatever they feel like.
Haven't done this on the, shop floor for a long time, so I did realize how difficult it is. So it's so pity, isn't it?
Yeah.
But I think you as a team did very well, just to start with, Chris, the way you approached the parent was lovely. It was actually, and parents do remember what is first told to them, and it's very important. Gabby, very well done. Vicky, very well done. But you said, escalation. And that's a very important thing to remember. With regards to NG tubes, I forgot to mention there, if the child has reduced consciousness and a severe DKA, NG tube is fine, simply because there is a degree of gastroparesis. These children are ill by mouth till they come off the pathway. If they have mild or moderate DKA, you can give them little sips. Otherwise, they'll start vomiting and there's the risk of aspiration. With the hypoglycemia, I think you'll recognize it, and Chris, that is very good of saying 10% dextrose. Start 10% dextrose, it's just 10 grams of carbohydrate in 100 grams, so it's fine. With hypokalemia, just watch out for it, because people are a bit wary of it, of escalation. Central lines, good call, good shout if there are ECG changes. But central lines in children with DKA, they are at high risk for thrombosis. So we would be a little bit careful, and it would be the last resort, like I think well done. I did realize how the team.
Do you mind if I take a photograph while you're finishing off the Twitter? Has anybody got any objections to the photograph? Okay, I might come the other way. Just stay over there. I might come the other way.
And I want to just go into one. I know most of you work in, medical areas and it's very familiar, but if anybody does want to go over injection technique or giving a subcut injection links, then please feel free to, stay behind, and I'm happy to go through it, because it's not something, maybe if you work in our wards, it's not something you do all the time. So if it's a while, you will have to go through it. But I know probably that most people are quite happy. But, feel free to have a go. Are there any questions? Was there anything that
Sorry, on the last part about making up the fluids and all this? It's so long since I looked after someone on the path. Was that all in there?
This wasn't there.
Making up the IV fluids.
No.
That's also been scary. But it's all clearly written.
It's clearly written.
Nice,
It's
isn't it?
useful, yeah.
When you're in a class. It's nice
Earlier,
to
we
see
had
that.
the all
Yeah.
Wales pathway, but
Yeah.
we've done the England and Wales now.
Right,
So
okay.
it's combined, it's structured across both countries.
Yeah,
So that's better.
that's good.
But the pathway still says bolus fluids is 20 mils per kg, but APLS has changed it, and we will change it in the new pathway to 10 mils per kg. And again, you follow the APLS guidance for a shock patient. You give resuscitation fluids, whereas rehydration fluids for the non-shock patients.
I think the other thing we kind of skipped through a little bit just on the sound there. Obviously, because initially, obviously, you don't start with any dextrose in the maintenance fluids until you get to, I think it's 16.
Yeah, 14. Yeah.
14, and then you add some dextrose in, and then obviously you get a little bounce because you get them some sugar. So actually, your BMR actually increase for the next hour or two.
Yeah.
And then you get the decrease again to the point where you get down to 5 or 6. And then you add the 10th, and the same thing happens. Quite often, I have seen it with some of the doctors. They're like, oh, it's going up again. Then you have to just kind of take a step back. I say them to take a step back and watch it for a couple of hours, because it will climb a little bit. And then you'll get the plateau, and then you'll come down. And it's always about 3 or 4 in the morning when actually something, oh, I'm doing something wrong here. It's just be patient with it.
And
But that's why
it's the glucose, you don't worry about it too much. It's ketones. The ketones are the naughty ones.
The spike you mentioned, do you find it when you check the sugar, it goes up? Do you find that the ketones
No.
They don't, they'll stay
Yeah,
there.
they stay there, yeah.
So it's
Ketones take some time to change. The blood gas dips is a bit Chris. The dips before you, it normalizes. So don't get too worried about the dip. It will normalize, but you have to watch the ketones improving hour on hour. It's the blood gas which will dip. The blood glucose will dip and bounce based on what you're giving them. But